Primary hyperparathyroidism is a common disorder that arises from autonomous overproduction of parathyroid hormone by abnormal parathyroid glands. It is characterized by the persistent elevation of total serum calcium levels with corresponding elevated or inappropriately normal PTH levels. Primary hyperparathyroidism and malignant tumors are the most common causes of hypercalcemia in adults. Autonomous PTH secretion may be attributable to hyperfunction of one or more glands and is caused by three different pathologic conditions: adenoma, hyperplasia, or carcinoma. Lithium-associated hyperparathyroidism occurs in up to 15% of long-term users. The diagnosis of primary hyperparathyroidism is biochemical and should include serum total calcium, PTH, creatinine, and 25-hydroxyvitamin D levels. A 24-hour urinary calcium level is important to distinguish primary hyperparathyroidism from familial hypocalciuric hypercalcemia, which is an autosomal dominant disorder of the renal calcium-sensing receptor that can mimic primary hyperparathyroidism. Familial hypocalciuric hypercalcemia should be considered in patients with long-standing hypercalcemia, urinary calcium levels less than 100 mg over 24 hours, and a calcium-to-creatinine clearance ratio less than 0.01. A 24-hour urine measurement of calcium and creatinine should be considered in patients undergoing evaluation for possible primary hyperparathyroidism. A careful history should be performed for objective renal and skeletal manifestations, including nephrolithiasis, fractures, and osteoporosis. Subjective symptoms, including neuropsychiatric, cognitive, musculoskeletal, and gastrointestinal complaints should be documented. In patients with suspected primary hyperparathyroidism, a personal and family history should be taken as 3% to 5% of patients occurs as a component of an inherited syndrome. In patients with asymptomatic primary hyperparathyroidism, abdominal imaging should be performed for detection of nephrocalcinosis or nephrolithiasis. Bone mineral density should be measured at the lumbar spine, hip, and distal radius in all patients with primary hyperparathyroidism. Genetic counseling should be performed for patients younger than 40 years with primary hyperparathyroidism and multigland disease and considered for those with a family history or syndromic manifestations. Germline inactivating mutation of the MEN1 gene causes multiple endocrine neoplasia type 1. Germline activating mutations of the RET proto-oncogene result in multiple endocrine neoplasia type 2. Somatic PRAD1 rearrangement upregulates cyclin D1 and sporadic adenomas. Parathyroidectomy is indicated, and is the preferred treatment, for all patients with symptomatic primary hyperparathyroidism. Parathyroidectomy is indicated when the serum calcium level is greater than 1 mg/dl above normal, regardless of whether objective symptoms are present or absent. Parathyroidectomy is indicated for objective evidence of renal involvement, including silent nephrolithiasis on renal imaging, nephrocalcinosis, hypercalciuria, or impaired renal function. Parathyroidectomy is indicated in patients with primary hyperparathyroidism and osteoporosis, fragility fracture, or evidence of vertebral compression fracture on spine imaging. Parathyroidectomy is indicated when primary hyperparathyroidism is diagnosed at 50 years or younger regardless of whether objective or subjective features are present or absent. Patients who choose not to undergo surgery should undergo annual biochemical evaluation and periodic DIXA scan. Patients with primary hyperparathyroidism may have higher rates of myocardial infarction, hypertension, stroke, congestive heart failure, diabetes, and mortality. Imaging is performed after deciding to proceed with parathyroidectomy and is performed for operative planning. Cervical ultrasonography performed by an experienced parathyroid sonographer is the least costly imaging modality and, when combined with sestamibi or computed tomography, is the most cost-effective strategy. Preoperative vitamin D repletion is advised and should be performed carefully in patients with hypercalciuria. Immediate autotransplantation is recommended for normal parathyroid glands that appear devascularized. Cure after parathyroidectomy is defined as the re-establishment of normal calcium homeostasis lasting a minimum of 6 months. Symptoms of postoperative hypoparathyroidism include perioral numbness and fingertip paresthesis.